topic is very interesting for me, and time is given very short, so let me do some justice. So let's be short about epidemiology. There are a lot of things already covered by Professor Javle, so I will not be repeating again. But one thing in for the audience I have to tell here about the epidemiology. So I would not accept this fact that in India we always call it is the Ganga River and the Ganges belt. This is how we spell, and we see that always that is a Ganga River and the pollution all around. But no, it is the sub-Himalayan region, and very characteristic throughout this country from Afghanistan till Burma and the Malaysia, everywhere the disease in, and in fact in Thailand, the northeastern region where the volcano is the subvolcanic region where the maximum incidence of cholangiocarcinoma is here. I don't know whether to deal with anything about the tectonic plate. That is a matter of research. But yes, certainly there are certain common reason for the epidemiology of this cancer, and the study by our favorite Avinash Pandey from Bihar, from the Tertiary Care Center Institute, in his study he clearly showed that gallbladder cancer is the commonest malignancy. So whatever the registry fed to the Globocon, I believe it is highly inadequate. It does not give the proper representation of the cancers in India, as it only accepts the or takes the feedback from only 4 cancer registries. So after learning this about the epidemiology, let's see what about the screening and prevention. So there is some work is going on. So the our prestigious institute from the northern India, the PGI Chandigarh, the Dr. Pankaj Gupta and Usha Datta madam from the Department of Radiology and the Gastroenterology, they come with this fantastic idea, and even Professor Jowli was a part of this international work. In this, for the first time, as per the BIRADS, LIRADS, now the GBRADS saw the day's light. With this, in future, with the prospective validity, and there will be a methodological reporting of the gallbladder lesion, and whatever there are the irregular thickening, which is always considered as a suspicious lesion, will be considered as abnormal and will be evaluated accordingly. So this irregular thickening made our Brigadier H.P. Singh to lead this work about the ultrasound guided screening of gallbladder cancer in healthy volunteers at Command Hospital, Lucknow, way back in 2014 and 15. He started this work. I just did the analysis of this work, and we presented this abstract in the ESMO 2020. So there is a definite evidence that you can catch up this disease early, and there is a survival advantage. Though the series of limited to 800 patients, 800 healthy volunteers, and it was compared simultaneously with the patients reported during that time to that hospital. If you compare the screening detected GBC and compare with the control, yes, certainly there is a benefit, and this was a proof of principle to take on the larger trials in our setup and save many lives. So now majority of the treatment aspect covered by Professor Javle. But when I come and when I always talk about the GB, it's a very sad part. Sometimes I feel when these NCCN body, the members, they sit and try to find out the guidelines, frame the guidelines, they must be confused. क्या करना है इसमें? तो इसमें कुछ है नहीं. There's nothing. And every time I see there's only 1 or 2 bullet gets added, and there is no proper algorithm. But yes, certainly things are changing, especially in last 6 months. Again, the problem here, if you see, is about cholangio, but it is not gallbladder. When you see the gallbladder, I'm not going about this trial, but one thing which I have to tell here, that there is a work done by the people across the world, the Capox versus Gemox, then the Gemox plus Arlotinib versus Gemox. Though there is no statistically significant in this Arlotinib trial, but see the PFS, there is a 7-month PFS benefit with the combination with the TKI, the way we practice these days in India in lung cancer, as the study published by the Kumar Prabhasar and the Vanita. So these are the summary of the phase 2 trial. I'm not going back. These are the two landmark studies. I will say that the Anand has done a great job along with Professor Atul Sharma. This is a GB Select study in which the second line, the combination of cap-IRI versus single agent irinotecan studied, and they showed that the irinotecan is better choice than the cap-IRI. When you go and see what is the GB cholangio, and it is the same, and when you tell about the story of 2 drugs or 3 drugs, what happened with this Prodis 38 Amebika or Ambika trial, this is what I'm going to spell. The authors just narrated in a simple conclusion that the modified FOLFIRINOX did not meet the primary objective endpoint, and that's why doublet it remains. So is a treatment of choice. But do you agree this? What happens if you dig in the data? What is happening here? See, what happens gallbladder. The curves are the forest plus is always different for the gallbladder, and we say that it is a small number, but certainly there is something hidden truth behind this, and it should be explored. This is a study of new adjuvant modified FOLFIRINOX, again by Professor Atul Sharma sir. And in this, there are impressive responses, partial responses, and the resectability. As already been told that these are not same diseases like intrahepatic, extrahepatic, CAT scan, there's a Hilar and the gallbladder. Even the percentage of the target is different. So like blood cancer, the breast cancer, the gallbladder cancer, or the biliary tract cancer should be treated separately and should be studied separately. That's what my take. So as already mentioned about the ERBB2 amplification, and this is, if I again don't take the name of Professor Javle here, because he was the pioneer in looking for this target and treating it with the trastuzumab in his study published in 2015. In that, 9 patients were there, and there are several weeks of benefit in the second or the third line with the patients who have HER2 amplification. So this was the group we form in northern India. We come together and try to see what happens with these patients if we add trastuzumab. So we had a good overall response rate of around 70% in these patients. We enrolled 36 patients, and out of that, 21 received first-line chemotherapy, Gemcis or Gemox, plus trastuzumab, and I enrolled the second-line patients as it was my study was going on, and both the things were permitted, and there were 5 patients who received therapy in the second line. These are the combined analysis, which was published in ASCO as abstract. So we did this study. The FMI supported this project by providing the evaluation sample. We did this study on 50 patients at Army Hospital RNR, and to a surprise to us. And what are the spoken words recently about the mutations along with the amplification? There are 30% of the patients will have HER2 mutations, and there are concurrent multiple mechanisms of resistance which are present. So I just going to show you the 2 cases in our study, how we have treated. This is a 50-year-old lady from Punjab. So this was her report. There was a ERBB2 mutation S310F, which is a known mutation in breast cancer. Though in breast cancer, the mutations are extremely rare. There is only 1 or 2%, and there was concurrent amplification. So this was the first line. The patient progressed as our study mandated. Only in the second line, we permitted the treatment, and then this is how, while after adding the lapatinib to the trastuzumab, the response maintained for 6 months. She did pretty well. That's the second patient. Second patient is a 70-year-old female who again come with the extensive disease. Biopsy couldn't be done, but our surgeon went in and do the laparoscopic biopsy and got some tissue. And this is the tissue we got. And this is the report on the FMI. And when the patient did not respond to trastuzumab, we go and look back to the VUS part of the report, and there was ERBB4 mutation, whether it is conferring the resistance or not. But this is what happened. Again, in this case, we given the lap cap in the fourth line setting, and patient did well for around 5 months. And you can see the PET scan report. There is definitely response to lapatinib while adding to those mutations. So I will not going to touch upon this. Again, just to highlight here about the immunotherapy, see what is happening, the gallbladder cancer. The hazards are 0.94, though the numbers are less, but I still feel the gallbladder should be studied separately for the IO combo with the chemotherapy. This is about PDL1 and MSI. Somehow the MSI is not a common thing, but there was a very nice study from Korea, wherein the pembrolizumab, they have studied in the second line setting, and in those patients who had TPS score more than 50%, in those the responses were very good. And this was kind of desperate oncology, or the precision oncology we call. Such kind of patients certainly do benefit. In our setup, to do such kind of studies with the immunotherapy is very difficult. But in what are the chances we have in certain scenarios with the TMB, we by and large we go ahead with the immunotherapy in the second or third or the fourth line. But some of my experience with the two patients with the TMB high was not good with the pembrolizumab in gallbladder cancer. So this is already covered. One word about the vaccine. There is a very nice article published by the Akhilesh Pandey for the ELF3 gene particularly, which is a candidate for the gallbladder cancer. And there are numerous such candidates, and studies are ongoing. The data on the anti-EGFR antibodies is negative. It doesn't help. This has already been covered. This is a case report by Viraj about the BRAF in the cholangio, which has, and there are several now case reports are coming that it is going to get benefited with this such targeted therapies. So in just to conclude, my point here is the gallbladder. Gallbladder needs to be addressed separately. And certainly there is a bright future ahead. But my only point is, yes, unless we don't collaborate, this dream is not going to fulfill. And the irony of drug development, I still feel the way the now durvalumab trial came to India, I expect the other trials also be focusing on India, the other countries where the gallbladder or the biliary tract cancers are high. I don't know when these we get the real amalgamation of the East and the West. So these are the GB warriors, which are they keep motivating me for taking the work ahead. Now, thank you very much. I finish here my presentation.